Thank you very much, Martin, for that very interesting and exciting talk. And now it is time for our panel discussion. And let me invite another three panelists to come join us. We also have Danvik, who has kindly agreed to chair, co-chair this panel discussion with me again. And our first panelist actually needs no introduction. Eamon Murphy, who is the Regional Director of UNAIDS for Asia and the Pacific. And our second panelist is An Rianto, who is the founder of Jaringan Equals Indonesia, or Equals ID in Indonesia. And last but not least, it is my pleasure to introduce Dr. Iskandar Aswa, who is an Associate Professor of Infectious Diseases at the University of Malaya, Kuala Lumpur in Malaysia. Thanks all for kindly agreeing to be part of this panel discussion. And we have a lot of questions coming in from the audience, so I would like to thank the audience as well. So let me start with a few questions, and please feel free, each panelist, to ask each other the questions, or even if I direct certain questions to some of you, and if you would like to join to chair, please feel free to always jump in. I think we would like to make this as informal and fruitful as possible. And we have seen a lot of questions around how to implement U equals U in the clinics. And I think like people now, and I'm glad that we don't see many questions about the science of U equals U anymore, you know, because in our previous years forum, this always coming up. Questions around uncertainties about U equals U science. So if I may, can I direct the first question to Dr. Iskandar first? I know you don't expect you to be the first person to be asked, but since you are among us being the infectious disease doctor, and we have heard from Sarah that 23% of ID doctor actually have not been talking about U equals U with their physicians, and the proportion of providers not talking about U equals U may be even higher in our region or among other non-infectious disease primary care providers. So for you, do you think that there could be any strategy related to peer pressure that we have heard from Sarah, from Bruce, that we can probably use or start to explore in our region, or maybe you can start with in Malaysia?
Yeah, so I think it, so when it comes to infectious disease physicians, if I could maybe just start with that, I think infectious disease physicians generally cover, in Asia anyways, a very large area. So from antibiotic resistance to HIV to tropical diseases. And we eventually sort of fall into our areas of niche eventually. Where the problem lies, I think, is how we as individuals and as doctors feel comfortable about talking about sex. Because ultimately it is about that. A lot of infectious disease physicians may go through the motions when patients come to clinic and end up concentrating on their medical management, so primary CD4 count, viral load, and comorbidities. But certainly in the Asian setting, I think, you know, and I can speak to maybe to a lot of physicians who practice within this area, are maybe a bit more shy when it comes to bringing up issues around sex. And so therein lies one of the problems. If we're not asking the right questions, we're not going to get the right answers. So I think that is part of the issue. You need to feel comfortable about talking about sex if you're going to talk about U equals to U, because U equals to U largely applies to sexual transmission of HIV. And then added onto that, you have a very conservative setting within a lot of countries in Asia. But on the other hand, I mean, and I'm trying to think about my own clinical setting. Maybe 50% of infectious disease physicians in my clinic will feel comfortable about talking about sex. But we generally, I feel quite confident as a rule to apply it, certainly to new patients when they come to the clinic. Because we know the host of advantages around talking about UICU in terms of viral suppression, in terms of adherence, and in terms where it's certainly changed management for a lot of our patients in clinic is for management of reproductive health needs and plans about future conception when it comes to HIV serodiscordant couples. So we no longer have to refer patients for expensive or more expensive sperm washing and technologies around that. So if you're applying U equals to U in that situation, really you can, it goes back to having sex naturally. Now, for those, but a lot, so in that sense, you're preaching to a lot of the converted. So the question is, what do you do for those who are not bringing it up and understanding the reasons why? I think it does need to come at a higher level. Leadership does come into it and prioritizing it as part of management of HIV individuals in clinics. It always helps if it's in the local guidelines and in the hospital guidelines, particularly around management of HIV. And maybe even higher up at an institutional level. We've had about, the last 3 World AIDS Day we've had in trying to speak to other physicians about U equals to U has always centered around U equals to U, and it never wears out. I mean, it still is a topic that is of utmost importance that we need to get out. So maybe in answer to your question, I think we need to feel comfortable talking more about sex. And it applies to STIs and pregnancy as well. Leadership, it needs to come from leadership, both at the institutional level and also endorsed by local organizations. So for example, although U equals to U has been endorsed by a lot of international, highly respectable organizations, I'm not aware that our own organization has done that. And that's something important to do for us anyways.
Mm-hmm. Thank you very much. It sounds simple, but to make doctors being sex positive in our region, I think it's very challenging. No? Talking about sex may not make you look credible. And when you talk about condoms, then certainly it makes you feel much more credible as a doctor. But I take that point, and I think that although we have not started yet, we may need to start and investing in having a new generation of doctors who can talk about sex. And also part of that is related to leadership, Iskandar. So maybe before I go to the other panelists, Eamon, because of your role in leadership in our region and the related to the recent discussion around U equals U when we finalized the political declaration this year. I just would like you to probably tell us a little bit more on how UNAIDS this year and next 5 years will endorse U equals U more strongly, or even like to play a role in encouraging, supporting, and kind of pushing countries. I'm saying this at like UNAIDS role at a country level in making sure that they really integrate U equals U into their guidelines or into their national strategies beyond just having U equals U poster or campaign on World AIDS Day.
Thanks very much, Nadia, and particularly thanks for inviting me to this panel. I learn a lot more in these panels, I think, than I share, and particularly having someone like Bruce and Sarah sharing their global expertise on these issues. Always in HIV, one of the most intriguing things is we've always had that front line, the implementers way ahead of the policy, right? That's natural in the type of process we've got. Even the science, the innovation around science is always ahead of the policy changes. We're seeing that now, but this year we have particularly two important events coming forward. And one of those is the new global strategy, which enshrines U equals U as part of the way forward. But then more importantly is the new political declaration, which was just signed last week. Ironically, I was in New York for other reasons, so I saw it on a laptop like everybody else, right? I think lots of people thought I was in the room because we're in New York. But I think there are a couple of things. Firstly, let me comment on the political declaration process. This time it was a vote, which is unusual. It's meant to be more a passive consensus passing, if you like. And I use passive carefully because we're at a stage in the response to HIV, particularly in our region, which is a bit stale. It's a bit stagnant in some sense. So for the countries to actually push the button and reaffirm their personal commitment, I thought was really powerful. And we had such a uniform and strong response and support for the strategy. A lot of new things in the strategy. U equals U is there. Leadership in these processes comes from countries and country experiences. So Thailand and Australia in our region, particularly Thailand, introducing the language on behalf of a number of countries, was critical in getting this language in. WHO came in and supported the language with the science so that it was well understood. So it was easily there. The reality, though, of course, is now how do we translate that? We have a clear commitment to U equals U in the political declaration, which is even more powerful than the global strategy, because the global strategy is adopted by a board representing many countries, but they're not there. Political declaration, they actually push the button to join that. So this is important because the context of the comments from Bruce and others about the sex negativity, that's not just for U equals U, that's the same for PrEP. Why do we have the Anti-Condom League now promoting condoms instead of PrEP, right? It's this comfort around, can we talk about sex? You know, is sex a good thing, you know, to be promoting in a sense? So we've got this, but I also see this as the entry point for us. Another way of pushing some of the programmatic changes that are still not happening at the scale we need. So combination prevention, treatment as prevention is U equals U as a new way of pushing this agenda. It means service changes and improvements in quality of care. How many people can access viral load testing frequently enough for them to have the self-comfort to overcome the many years of almost indoctrination of the system? And that's what we just heard from Sarah too about doctors and clinicians. You know, we've been working in one dynamic. Now we have to change that. So UNAIDS will work through a new regional roadmap, which will follow up from the political declaration. ASEAN member countries have already said they are calling for one, SARC. The country officers will be introducing U equals U as part of the combination prevention and treatment as prevention elements, because it is also a stigma and discrimination, a connector. So it's the intersectionality, as Martin was talking about with stigma and discrimination. If I'm living with HIV and I know I can't pass HIV, that gives me a whole new sense of power in my own life and a different level of self-worth. So there's a whole range of benefits out of it. So we will be working with countries as we introduce the new targets, update the policies to make sure U equals U is enshrined, but as was said by the previous speakers, understood, and that's going to be critical. So social campaigns are going to have to be critical part of this, and we're going to have to work with other partners, technical partners, community partners to get the message out, because it's not just the clinicians and the policymakers, but it's the community themselves. We need to get them to understand so they know what to ask for, because that has always been one of the significant things. The community themselves create the change by knowing what to ask for and what services to expect. I can hold there because there's a lot of interesting panelists and come back in with some other aspects as we go forward. But it really interesting discussion on how we can move this forward. But it's got to be a critical part of the new agenda for the next 5 years if we're going to catch up in this region, because we haven't met the 2020 targets and there are new targets set. This is, I see as, in a number of ways, to connect elements of the weaknesses in the current response.
Mm-hmm. Mm-hmm. Thank you very much. I think we are at this time being a very good and having this like positive environment of at least having something written down that countries can refer to, and just to share with all of you, during this like political declaration negotiation phase, I found it quite surprising, you know, like people are asking because it's Thailand who is proposing this language, and then the government asked if we have anything written about U equals U, you know, and I couldn't find anything in our region except for ACHIM guidelines, right? And then what I can share actually was all those statements that were issued last year when we have this like U equals U crisis in the country, and that was a really good event when I like reflect it now. Okay, it generated a lot of statements that we can use to back up U equals U in our region at least. Yeah, so that's the situation. So now let me ask Anne, and then I will go to Martin, because like we have heard from Dr. Iskandar as kind of the provider of what he feels would encourage U equals U implementation in the clinic. But to I think it would be really nice to hear from you of what you actually would expect the clinic settings to offer to you, or what you would like to actually empower you yourself and your communities to be able to start the discussion or initiate the discussion in a clinic setting, or even in a community at a wider scale. Maybe Anne first.
Okay, thank you, Dr. Nitayang. Well, actually, I've been starting this education and advocating about the U equals U in Indonesia since 2018. But then until now, I really hope someone will back me up. Some government bodies or NGOs will back me up. But until now, until 2021, I'm still the ones doing the advocating in Indonesia about U equals U. I mean, this is very important for everyone living with HIV. I myself living with HIV since 2015. At that time, back that time, like 5 years ago, I don't know what to do. I thought my life was ended. I thought there was no medication for HIV. There was no cure for HIV. Now I learn about U equals U. It deliberating me about everything. It gives me deliberations about that I can live like my normal life. Normal in, I mean, just like before I got positive. So it's just like I hope I can live like other people living without HIV, which is from Bruce. I learned a lot about the U equals U. That I can have the freedom from fear of transmission to my partner, to others, that I can live without stigma, that I can fight the stigma, that I can say to someone that, hey, I live with HIV, that's okay. But you know what? I'm not going to transmit my HIV to you because I'm undetectable. I stay on my treatments. I know how it works and I will stay on it. I will keep you safe. That is my promise. So this way, I encourage my community to learn about the U equals U, even though when they ask about to the doctor, the answer is no. I heard about the U equals U. That's what the doctor say. I heard about the U equals U, but it's in another country, but it's not going to work in Indonesia because you know the Indonesia is a different setting of culture, of habits. So I don't believe that U equals U is also work in Indonesia because there is no evidence base in Indonesia. I mean, I myself is a live proof. I proved that my partner was negative for like more than 10 years. I was in a relationship with my boyfriend and she was negative. And we did it without condom. So that's a proof. And also I have a lot of friends in my network that they can have a children, they can have a wife, they can have a partner without transmitting HIV. So what are these if this is not a proof of U equals U? I don't know, but I think so, like what we said earlier, we've discussed earlier that I think so, that medical practitioner or doctors is not comfortable talking about sex. Yeah, I mean, so we are in Asian country, we know about this. Even in Europe, I think people don't want to talk about sex. Sex is considered a taboo. If you don't talk about sex, then how can we educate about the STI? How can we prevent prevent the HIV? HIV is part of the STI. Just by giving the information about the U equals U, people can stay on a treatment because they knew once they stay on a treatment, they cannot transmit HIV to their partners. They can stop the spreads. And I think this should end the stigma. And they should be able to fight the stigma with these informations.
Thank you very much, and I think we all share the frustration that you have, and I don't think that even in Thailand it will be very positive if you would like to discuss U equals U in with the majority of doctors who is providing HIV care in our country. There are still many more things that we need to do, and I feel that what you just mentioned actually probably can be related to the social information that Martin taught us during his talk, that somehow like being a doctor or being a PLHIV advocate to start talking about U equals U, this may send some social information which may be judged by others. So maybe Martin, you can talk about that much better than me. So please go ahead.
Thanks for the segue. So it's true. So when you talk about U equals U, first of all, for a person living with HIV, it's disclosure. You are associating, or you're talking about treatment, and people will ask, so why are you talking about U equals U? They don't know you're HIV yet, right? So that's a possible association with HIV. And once they have that possible association, then all the labels that we've been labeling with stigma or fear or whatever on HIV will be then on you. Well, who wants that, really? That's number one. And the same with doctors, right? So if doctor talks about sex, in our culture, that's permissiveness. That's a no-no, as we all know. Is that the whole moral base is on how well you control your feelings, how well you comport your behavior, how well you attend to life. And if you start to talk about something that is viewed as a taboo, then it seems as if you have loose morals. You are going in that direction of loose morals. And similarly, that's stigmatizing already. You're transmitting a piece of information that you expect people to disagree. And because of the expectation that we're sending out, we are already projecting our own unease going out. So when I first, I'm publicly, I publicly disclosed that I'm HIV positive. I did that a few years ago, and it was a very tough decision for me. I'm expecting sort of social death almost, right? In gay life. I mean, Bruce, you probably can tell us more about this. And U equals U is a fantastic concept to put it into really basic terms. But it's so basic that we sometimes forget that almost three processes going in tandem. First of all, you're suppressing viral load, right? And that suppression, not everybody trusts. So when I first talked about U equals U, we have lab technicians, we have doctors questioning your undetectable viral load levels and questioning the possible spikes in viral load, which they know exists. But what they don't talk about is also transmissibility. So not only suppressing viral load, but the minimum amount of virus you need in your blood, the concentration in your blood in order to transmit the HIV. We don't ever talk about that. And that is so important in U equals U. So there are two processes there. The third process is it's a combination of two. We've been focusing so much on public health. We've been focusing so much on the patient, right? We want to treat the patient. We want to find the patient. We want to get them to test and then treat. Well, when you target one part of the population, what will you get? You get like a target on their backs. Who would want to be targeted really? We see this with COVID also. We are now targeting. We're looking for people, right, for vaccination, for testing, for the variants, and so on. Nobody wants to admit. Nobody wants to have a target on their backs. That is social information. That is stigma. Nobody wants to be known as a possibility of putting somebody at risk. So when we talk about risk is also relational. It's relating to how much you think you can avoid. And this is something that we have to really understand and maybe put ourselves also in the shoes of the person whom we're speaking about or speaking to, because although we talk about empowerment, we talk about being HIV positive can be very empowering, we are empowering our communities. But did you know in most of our countries in Southeast Asia, and I'm only talking about Southeast Asia, most of our countries in Southeast Asia, most of our focus is on the marginalized populations, so drug users, people who use drugs, people who sell sex, people who or LGBT and so on. Well, that label is also targeting, okay? Before, STI is everybody. So sexually transmitted infection affect everybody who have sex. But nowadays, every time we think about HIV or STI, we're thinking about people who are so-called unnatural sex or deviant. We put them into these little boxes, and then we want them to be empowered and we want them to be free. That is like a double jeopardy. And so we've created an environment now that we need to change. And we have to change, I think, beginning with ourselves and with our language and with our expectations. Helping people to disclose is a very important thing. And there are many, many fears. They fear being kicked out of their homes. They fear losing their jobs. They fear losing their livelihoods. They fear many, many things. And these fears we seldom talk about. And those are the little things, you see, because it is in these fears that is where stigma resides. And this is what is stopping you from going forward in our region. There are taboos, and unfortunately, that's the case. Thank you.
Yeah, I think that fear, uncertainty that maybe one of you talk about is something that if we don't make it clear, like to clear my mind, actually it's not clear already, but it's just to talk it out to clear our mind so that we can move forward. It may not go anywhere if we just like talk superficially.
Right. We assume a lot of things about a lot of people, I think, but we don't know. And when we don't know, and when we suspect, or we start to have many, many thoughts. And these thoughts, most of them are judgments, really. The mind judges. And most of them are discriminatory because we want to be safe. We want to be, we want to save ourselves, first of all, right? And our people we care about. Well, that's stigma. That's the source of stigma, right?
Yeah. Thank you, Martin. And to Bruce now, because you are the one who many of us have been looking to as someone who like be the strongest advocate for U equals U. Do you think that because of this, it may somehow cause U equals U to be seen as kind of a Western concept, that like for us here, we always think about, okay, it's partner one, partner two study. It's a thing, and no one really talk about opposites attract. That it's actually happening in Asia. Do you feel that by you being able to work with many countries in our region, do you think this kind of the Western thing, the colonialism thing, play any role in U equals U challenges?
That's a great question, and yes, absolutely, it does play a role, and that's why we're so lucky that there are advocates who are as strong or stronger than I am, like Anne and Martin in this region, who are speaking out, and and also Pete in Thailand, who it has been a problem actually in Uganda. Our activist William Matovu from Love to Love has said that the government believes in U equals U, the science, but they think that it's coming from it's promoting a white Western gay agenda because I'm a white gay male. So there are times when I really need to not be the face of U equals U, and there are other times when it's important where people want me to be a part of it. I think in Japan, when I visited and kind of did a speaking tour and lots of high level meetings, it seemed to be effective to have someone from the United States there speaking about it. But then in other places, it's better for me to be behind the scenes and help wherever I possibly can the activists, in the ways that they need and request support. So it's really about a case-by-case basis. And I think anywhere we go, even in the United States, if it's in the South and we're talking to young Black men or transgender women or whatever the audience is, it really is important to take a look at who the messenger is and to not kind of impose our any kind of leadership role that I might have in the campaign on any audience, and listen to what their needs are.
Mm-hmm. Yeah, that's an interesting point, and I think like we always can learn from each other, and like to share. I mean, to have you in our session here, I think it's wonderful because people would love to learn directly from the man who really create this terminology, right? And to really listen to that. Yeah.
Well, I think also there's so many leaders in the field, and it's in 102 countries and on every continent. So there's so many leaders to help support and elevate their voices, and that's something that we are really committed to doing. So thank you. I'm one of, I think, many leaders in the field, many who are much more effective than I am. I always look at Sarah's presentation and I look at it and say, I wish I could be more like her. She's so brilliant and clear, and all the activists on here, everybody on here has been great today.
Yeah, exactly.
More like you.
Thank you very much, and I'm related to that. Sarah, you mentioned about the role of education, the role of guidelines. I would love to hear from you if you can share any maybe successful examples from when you really make this into a formal thing, that it could help change the practice among healthcare providers, or even if this is like a small scale, or if this is larger at a country level, that would be very useful for us to kind of learn from you, because now we have some document to refer to. Now we may want to move forward in designing something based on that document and make it tangible actions here.
Yeah, so I mean, I think that that's something that needs to be done in terms of evaluating the impact of the various guidelines, and that's something that my team has been talking about. I don't think that I can present you with hard evidence that these guidelines have definitively made an impact, and kind of systematically teased out other variables that could have been a contributing factor. But I think now that we do have guidelines coming out, and there are all of these great resources. The CDC is putting out, the U.S. Centers for Disease Control are putting out a toolkit. Certainly, Bruce's website has a million resources. I think that the resources are there, the guidelines are there, the language is there. I've seen sort of small studies looking at sort of individual programs and educational programs, whether it's been sort of an acceptable program. But in terms of actual impact, I think that that's still to come. One thing I can say is that in terms of the work that my team is doing, we're really interested in understanding how U equals U and really comprehension of U equals U is having an impact on stigma. And so some of the work that we're doing around that is looking at how MSM who endorse U equals U, not just endorse it, but believe it. So actually express that there is 0% transmission risk, how that is associated with stigma. And one thing that really stood out, we've been talking a lot about HIV stigma and the potential for U equals U to reduce stigma. One thing that stood out in our data is that among men who are HIV negative, those who believe in U equals U expressed lower sort of negative attitudes towards people who have HIV. They themselves expressed a lower HIV stigma, and they also endorsed or reported that they had engaged in fewer HIV microaggressions. So that's just to say that knowledge of U equals U and not just awareness, but belief in U equals U really can have an impact on stigma. But to your question, I think that really there's a lot of work to be done in that area. And Bruce, you may have some thoughts. I don't know if you are aware of data that has systematically looked at the impact of guidelines.
No, I haven't yet. I know, we're working on getting guidelines updated, but not seeing it, how that's yet, affecting people. I think it will be a great study.
Yeah, I think there are some questions related to that from Scott as well, if I recall correctly, in terms of like how we measure the impact of having guidelines in the country among healthcare providers, which I think maybe it would be very interesting if this can be like in multi-countries or at least the regional research, looking at this in an implementation science way to really document something that other people, other countries, other regions can also look at and replicate as appropriate. Yeah. So like I mean, the intention of asking that question to Sarah is if there is any example of how this has been implemented. Actually, even if we haven't yet looked at the data, the endpoints of those studies, it would be good if it can be shared with those who are interested in starting implementing something. Yeah, and we don't have much time left. I will now give my microphone to Danvik, who has a very special question to ask all of you. You're on mute.
This question actually came from an audience, and I think this will also stand as your closing words for this panel discussion. And I would want everyone to answer their insights on this question from Prapan Panupak. U equals U or properly treated individuals will not be able to transmit HIV to others. That means HIV is now a treatable, chronic, non-infectious disease. Will this reduce stigma and discrimination and normalize HIV? I think we can start with Dr. Iskandar.
I mean, absolutely. That would be the intention of U equals to U, ultimately. But I mean, as we've heard in the presentations before, there is an issue with people believing that completely, despite the evidence, despite the very strong evidence, which is unfortunate, both amongst healthcare providers and the community as well. And you got to question why that is the case, really, because the science is repeatedly strong. So, but in answer to Prof. Prapan's question, it absolutely should. I think, to my Indonesian colleague who seems like he's struggling with getting the U equals to U message out there, you need to find a health provider champion in your country to fight the battles. You cannot fight it alone, and you will find there is always a health provider champion in the country. And you need to look at, and I think one way of promoting U equals to U in the country is about concentrating on all the positive aspects of U equals to U, whether it's allowing conception without condoms anymore, effect on decriminalization, effect on adherence. I think we tend to concentrate more around maybe the issues around sex and having to talk around sex, but maybe we just concentrated on the positive aspects of U equals to U. We probably would be making more leeway with the messaging.
Thank you, Dr. Iskandar. And how about you, Bruce? Your answer to that question and your final words.
Okay. Yes, I think absolutely. It's reducing stigma. I know we know that anecdotally, and we know that from some studies. And I think that internalized stigma, especially, is having an effect on U equals U having an effect on internalized stigma. Sorry, but I think there will still be the stigma because it's a sexually transmitted infection. There's a stigma around anything that's kind of sexually transmitted. So we have to always have to be looking at also helping people feel more comfortable talking about sex. And that's really challenging, especially in different parts of the world. But I think what we really need to do in this field is to treat stigma like a public health emergency, to realize how many people are suffering right now. They are suffering from social rejection, from depression, from suicide, from intimate partner violence, from prosecution, and from murder, because they and other people think they're infectious, and they're not. And U equals U is an absolute effective way to reduce that stigma and to alleviate that suffering. And we have to move from beyond giving lip service in the field to actually doing something, making this education a priority, not in paragraph 5, as I was saying in my presentation, don't bury it, but like the UN HLM declaration, make it a strong bullet point, or like PEPFAR, put it right up front as a requirement on its own. It stands alone. It's too new and uncertain, as Martin was saying. It's too radical for people to have it buried somewhere. It has to be repeated over and over again in order for us to really make an impact on stigma, on the lives of people with HIV, and on ending the epidemic.
Thank you so much, Bruce. How about for your final words and insights on this question, Sarah? Okay, well, we get back to Sarah. How about for your insights and answer to this question, Martin?
Sorry?
Sarah, go ahead.
Yes. Hi,
yes, Sarah, we can hear you now. We can hear you now.
Okay, great. I just got notification that my internet connection is unstable, so I apologize for that. I was just saying that, yes, I agree. It definitely can have an impact in terms of reducing stigma, reducing HIV, anxiety, helping couples or individuals who were previously comfortable having relationships with others of different serostatuses come together, and that in itself can reduce stigma. I agree with Bruce, the fact that this is a disease that is transmitted in a way that people are uncomfortable with, so through sex or through injection drug use. I think that can help, or that can contribute to ongoing stigma. I think also the populations that are disproportionately affected by HIV, as Martin spoke to previously, there is intersectional stigma, and those are groups that are already heavily stigmatized, and so those are other forms of stigma that need to be addressed. The other thing that I'll just mention when we're thinking about stigma, and I think that this was alluded to briefly, but just we need to be very mindful as we're moving forward with U equals U that not everyone has access to treatment, and therefore not everyone can be undetectable. And so we need to be very cautious that we're not contributing to greater stigmatization of those people with HIV who are not suppressed.
Thank you so much, Sarah. How about for your perspective, Martin, and your final words?
Thank you very much. A brilliant discussion. But one thing that I need to mention, and this is particular to Southeast Asia, is that science literacy is really quite low. I think we have to understand that. And we're talking about public health, we're talking about treatment, even chronic illness. They're all rather difficult concepts for some people. So they don't understand that you can have a disease that is recurrent, and they don't understand that maybe you have to take the same pills forever for the rest of your life. They don't understand that concept, and the way they think and the way we approach it, I think, requires a different, a more nuanced approach that perhaps looks at what people are able to accept, and then provide the information that they can integrate. So one reason why U=U is difficult for some people, and this is coming from a community from Nepal, Paul Chan, who just sent me a message. He left a question on the web, but he said that there are some people who are really afraid that if treatment is prevention, then people will say, "Oh, I don't have the virus anymore," right? They misconceive that they've been cured, and that has to be made very clear. You can be living with HIV, but normally, you can be living with HIV healthily, like you are living with any other chronic illness. So we need to really work on this and take the fear out of it. And that, I think, is a policy issue also. Thank you very much. Great talk.
Thank you, Mark. Thank you, Martin. How about for you, Anne?
Okay, thank you. So I guess your culture is not just about the sex liberation if they don't want to talk about sex. It's about the well-being of people living with HIV. It's about the well-being of every human being, that we need to treat every human being with the humanity. I think that's all the message if they don't want to talk about sex. And if they still don't want to talk about it, okay, let's go with the last 95% global targets. Viral load suppressions. We go with that. I mean, so people knows the U=U, they would not quit the treatments. They would stay on the treatments. They would not transmit HIV. So we can reach the global targets. We can end HIV, even though they don't want to talk about sex.
Thank you. Thank you for those insights, Anne. And finally, for your perspective and insights, Iman.
Thanks, Janvik. I think Anne said it really well. We can use this as a driver to get to the end of AIDS. But will it stop stigma and discrimination? Asia Pacific, HIV is an issue of the most marginalized in societies. The stigma is embedded about the people themselves and their lifestyles, their behaviors, their identities, whatever way you want to describe it. So no, it won't get rid of the stigma and discrimination, but it is a tool we can use to push these issues, help fix the system so people do have access to the viral load, so they know their status in terms of viral suppression, and it can be a system tool. The stigma and discrimination, absolutely, and others said, self-stigma, the full gamut we can look at. But as Henry said in the chat, his question from Indonesia, we need a multifaceted response to this. And that's both for policy, for the community. We need to re-energize the conversation about this because there are so many positives out of using U=U in the dynamic for both prevention and treatment for the whole service coverage, so which will impact on stigma as well, but empower people themselves. So thanks very much. It's a very powerful discussion this afternoon. Back to you, Dandy.
Agree. This is a powerful discussion that we had, and we apologize if some of the questions from the audience were not answered, but they will be answered in a separate manner. Thank you very much to all of our speakers and our panel. We very much gained a lot of knowledge from your different insights and perspectives, and we really hope that the knowledge and the concept of U=U will be spread out there, not only to those, of course, who have HIV, but also those who are needing this necessary information. Thank you. And over to Dr. Nitya.
Thank you very much. And I would like to thank all the speakers here, the panelists here again, and also the audience for joining us today. And we hope that we will see you again Not next year, but tomorrow for the APAC conference. But then next year, certainly for this Asian Stigma and Discrimination Forum. Thank you very much.
Thank you. Thank you all.